So good morning, my name is Bill Smith. I'm the Executive Director at the National Coalition of STD Directors. We represent the 65 directly funded programs, STD programs across the country that the CDC's Division of STD Prevention funds really to do the nation's work in preventing STDs and doing STD control. We also have an additional nearly 1,000 members working in both public and private settings across the country working on STD prevention and sexual health promotion. And we're really happy today to sponsor this briefing along with a number of our co-sponsors that I'll talk about, and really thrilled that we were able to involve the CDC's Division for STD Prevention in this morning's briefing and some other partners. So this morning, we're really focused on the title that is in front of you and those two little critters sitting up here on the front table, which is syphilis. So for those of you from congressional offices, I hope one of these landed in your office. We sent little microbes, either syphilis or gonorrhea, to every Hill staff over the last 2 days, I think, promoting the briefing. So everyone on the Hill got syphilis or gonorrhea this week. But we're really focused on what is happening with the nation's STD epidemics, and in particular what's going on with a significant resurgence in syphilis, and then to talk about what the public health infrastructure and response looks like and needs to look like in face of that resurgence. So, making sure it's not an alarm. So, I'm not going to do too much setup because I think we've got two really incredible speakers today. But what we really want to draw your attention to, again, are increasing STD epidemics and some of the challenges that we're having in responding to them. And this Division of STD Prevention from CDC will also inform you on how federal resources are currently being used to deal with the STD epidemics. I want to start also by thanking my colleague from NCSD, our Director of Policy and Communications, Stephanie Arnold-Pang, for all of her work in putting this together today. Huge thanks to Senator Blumenthal and Congressman Honda for being our honorary co-sponsors, and thanks to their staff. Sorry if I butcher names. Helen Boudreau, Lauren Gee, Brian Steele, Sarah Iman, and Sean Campbell. Thanks to all of you for working with Stephanie and getting the word out on the Hill about this morning's briefing. I also want to thank our co-sponsoring organizations of the briefing this morning. That includes the AIDS Institute, the American Sexual Health Association, the American STD Association, the Association of Public Health Laboratories, the Association of State and Territorial Health Officials, the Association of Maternal and Child Health Programs, the Georgia AIDS Coalition, the National Alliance of State and Territorial AIDS Directors, the National Association of County and City Health Officials, and the Treatment Action Group. So huge thanks to all of those organizations as well for sponsoring this morning. So I would like to introduce both of our speakers. They're going to come up and talk in turn, and we will do Q&A at the end. And just before I sort of talk a little bit more about what we need from Congress moving forward. So I will introduce Dr. Bolin, then I'll introduce Dr. Gales, and Dr. Bolin will go first. So Dr. Bolin is the Director of the Division of STD Prevention at the Centers for Disease Control and Prevention. She began her public health career as an Epidemic Intelligence Service Officer, or an EIS officer, and the Respiratory and Special Pathogens Branch at CDC. She gained international experience with a 3-month meningitis surveillance project in Burkina Faso. And following IAS, she completed an infectious disease fellowship that included bench research on the characterization of the Neisseria gonorrhea, iron-regulating protein that was thought to be a potential vaccine antigen candidate. She earned her medical degree from the Dartmouth Medical School in Hanover, New Hampshire. She completed her training in internal medicine at the University of Virginia, Charlottesville, with a subspecialty training in infectious diseases at the Tufts New England Medical Center in Boston and the Stanford Medical Center. And Gail, how long have you been division director now?
As my husband says, he counts 5 years and 3 months.
5 years and 3 months. And I just want to say, on behalf of NCSD, it's pretty rare that an organization like ours that represents parts of public health really have such an extraordinary partnership and collaboration with the division at CDC that heads that work, and we've really developed a very strong partnership under Dr. Boland's leadership to make sure that public health departments are empowered to do the work that we need them to do. So I just wanted to acknowledge that. Then we have Dr. Travis Gales. He's the Chief Medical Officer of the DC Department of Health's HIV, AIDS, Hepatitis, Sexually Transmitted Disease, and Tuberculosis Administration, or HOSTA. So much easier just to say HOSTA. And Chief of the STD TB Control Division in DC. He's a graduate of Duke University and the University of Illinois, where he completed his MD and PhD in community health, with, I guess, a concentration in health policy. He completed his residency in pediatrics at Northwestern University and a fellowship in academic pediatrics and adolescent medicine at Lurie Children's Hospital of Chicago. While at Northwestern, he served as director of the HIV Treatment and Prevention Program and faculty member at the Feinberg School of Medicine, Institute of Public Health and Medicine, and DePaul University College of Health Sciences. And I will say, Dr. Gales is still our relatively new member from the DC Department of Health, and he's brought some extraordinary energy to dealing with epidemics, STD epidemics that we have right here in our own backyard. So we've invited him today to give you a little bit of a perspective really around what's happening outside of these walls and here in Washington, DC, and to give you a little bit of an on-the-ground perspective. So with that, I'll turn it over to Dr. Boland.
Do you know how to put my
Stephanie's going to switch it.
Oh, okay. Thank you, Stephanie. Again, thank you to Bill and Stephanie and others for the invitation to talk today about sexually transmitted disease prevention. And as we're getting the slides up, thank you. What I'd like to do today is, first of all, give you a little bit of background on how STD prevention has been working in the United States for years. Traditionally, it has been a public health sector responsibility. We also work closely, as Bill mentioned, with our state and local health departments. The federal resources are not able to do everything, and so we're concerned about sort of the erosion of the public health infrastructure for our STD prevention and control efforts in the United States today. And also share some data that we have about why we believe, even with the advances of the Affordable Care Act and the improvement in access to care and coverage to a lot of citizens, we still have the need for publicly funded STD services based on some recent science that we have at CDC. And then obviously, I've been in the field for now over 30 years, and we're not going in the right direction. We've got some very disturbing trends, especially around syphilis. I know we've talked about the threat of untreatable gonorrhea, which is still a threat, but we're most concerned about what we're seeing in this country with syphilis, including congenital syphilis. So first, let me talk a little bit about sexually transmitted disease prevention and control. This has always been a joint responsibility of our federal government and our state and local health departments. And we've been having control programs that go way back to 1937, and for those of you who are interested in sort of the history of medicine, reading Tom and Perrin's sort of treatise on thesis on the shadow on the land, he put forward a bold approach to the syphilis problem at that time, which was the shadow, and was the first Surgeon General to really publicly speak about a sexually transmitted infection as a problem for our nation. Interestingly, the strategies that were put forward in 1937 are still the strategies that we're using today. We want to educate and empower people to know if they're at risk, that they need to come in and be evaluated and tested. We set up screening programs to identify infected people. We set up STD clinics, which originally were designed to take care of people on the same day with same-day treatment and not wait for a month to get an appointment with their primary care clinician. And these are mainly for symptomatic individuals who we think are more likely to be transmitting infection with higher organism load than asymptomatic individuals, as well as for contacts. We know that our bacterial STDs, syphilis in particular, is very efficiently transmitted, so we routinely will treat a contact with it without even having a diagnostic test, because we don't want to continue with further forward transmission in the community. And then in the field of STDs, as we have now for HIV and have had for TB for a long time, is that we really want to ensure people that have been exposed to these infections realize that they've been exposed. Most people don't realize they've been a contact to someone who has syphilis, and you will have a period of having no symptoms. So we do contact tracing testing for our syphilis cases, but that tool is dependent on knowing who your sexual partners are. And obviously we've got a lot of new technologies and way people are meeting partners that do not lend the same sort of locating information that we had in the past when people had a little address book and they could look up the telephone number and the address of their sexual partners. We also recognize in the work that we do in STD prevention that we've also been contributing to HIV prevention, given that HIV is a sexually transmitted infection. But there are also some reasons why it's important to recognize the contribution that STD plays to our HIV prevention efforts in the United States, because first of all, there's some biological reasons. Certainly if you have an open sore, and you're exposed to HIV, it's much more likely that that HIV will enter the body. If you have the inflammatory types, and the open sore is what syphilis generates, if you have the inflammatory types of STDs, chlamydia and gonorrhea, you can have higher viral load. That if you actually treat those chlamydia and gonorrhea infections, you lower the HIV viral load, so you're exposing partners if there's not protected sex. So we also know in general that STDs increase both the susceptibility to HIV if you're not infected and the transmission of HIV if you're living with HIV to your partners. We also know that STD clinics serve as a very important focal point for very vulnerable populations. Even people who have access to care sometimes don't want to see their primary care provider and kind of have to deal with the sex talk. And they just want to go to the STD clinic and get that same day confidential services, is what our STD clinics offer. So we recognize that HIV testing in STD clinics identifies a lot of new HIV infections and is a very cost-effective HIV prevention strategy. And when we've looked at also looking at sort of other factors related to men who have sex with men, gay men, bisexual men, STDs is actually the best predictor of who's going to have a new HIV infection. There's a lot of behavioral surveys out there, but if you want a simple biomarker of who's at risk for HIV, STDs are very good markers, and that includes syphilis as well as chlamydia and gonorrhea. We also know that STDs in gay, bisexual, or other men who have sex with men who are not infected with HIV, these biomarkers are also very important in identifying who's likely to become infected with HIV, and therefore are people that really should be having the PrEP discussion about other prevention tools available to them. So these are the ways that STD prevention is important to HIV prevention, and if the infrastructure of STD prevention goes away, it certainly has some significant implications on how you're going to find individuals that are not seeking care in STD clinics or in STD programs for your HIV prevention efforts. Now, I want to move now to sort of this difference between state and local STD prevention funding, because there's a lot of confusion about, does the STD program, pay for clinical services with our federal dollars? Traditionally, both TB programs and STD programs that were started back in the 40s, our federal resources were going towards core public health functions. That's going back to the basic assessment and assurance and policy. So our federal dollars support at the state and local level strong surveillance systems, a lot of provider training, because we recognize most of our STD patients are not seen in STD clinics with the asymptomatic type of STDs. They're seen in the general healthcare community, and a lot of providers don't get adequate training in both medical schools and nursing schools in terms of STD management and sexual health questions that they should be asking. And I always like to have people in the audience reflect the last time that you went to see your primary care provider. Did they ask you about the gender of your sex partners and the type of sexual practices and what you're doing? And that sort of reflects the state that we need to make improvements in. We also support sort of the contact tracing efforts that are done locally. Locals also invest a lot in contact tracing programs, but we provide surge capacity and outreach into the community with health promotion and health education. And we really do not have funds available for, direct clinical services supporting STD clinics. There's been a little bit of support for chlamydia screening for vulnerable women in settings at the state and local level. But it's really been the state and local health departments who are responsible for the clinical services, the care of their citizens. So it's state and local dollars that support STD clinics. And obviously we know when there was a great downturn of our economy a number of years ago, I'm going to talk a little bit about how we lost a lot of those clinical services, and today we're still being challenged by additional reductions in our infrastructure. Just to see how we spent our money in 2015, this pie chart shows how we use our federal dollars, and we're trying to work with our state and local colleagues as well as NCSD to also get a better understanding of what the local resources are at the state and local level that are available to complement our federal efforts. So 55% of our resources go out to state and local STD prevention programs in health departments. We have about 8% of our budget actually provides additional staff out to the state and local health departments. We call those direct assistants. So we actually place people in state and local health departments to provide surge capacity in the area of field service investigation, contact tracing, surveillance, and epidemiologic investigation. We have a limited 3% of our budget goes out to a network of clinical training centers that are trying to train our providers that didn't get adequate training in their medical or nursing schools. 3% of our budget goes to sort of some enhanced surveillance activities. We don't have the resources to fund separate surveillance grants. They're part of our main program grant, but sometimes we need new models and methodologies. You're going to be seeing some areas where we've got some gaps in our surveillance in terms of understanding what's happening. So these are our surveillance incubators, so to speak, in about 10 states. And then we've got sort of 1% of resources. We still are administering the Clinton-Tuskegee apology, and actually the commemorative is this week in Tuskegee that I go to every year, and the family members were supporting their medical benefits down to the grandkids for their life. And it's quite a privilege for our division to be able to be working in that program. And then we have a very limited budget. You can see it's less than 1% for our research and evaluation. We do have our 1% for partnerships. And then we have our sort of CDC supported 11%, and then our internal budget at CDC is only 8% for our staff in the work we do in the area of science, technical assistance, and policy. We've been trying to track what's been happening at the local level better, because we do a lot of disease tracking, but sometimes if you don't have a workforce, how can you actually control disease? So I think it's important that we start having workforce surveillance. And we've been looking at what state and local prevention programs have been doing and providing in terms of vital STD and HIV public health services. So local programs provide 80% of contact tracing in this country. A little bit, 85% is provided at the state level. The local programs provide about 71% of STD screening in non-clinical settings. This may be out in the field, community-based organizations, other places, and 25% of HIV field testing for STD contacts. And they also provide 65% of directly linked HIV positive individuals that are identified in the field. They haven't accessed care. We link them into care for both their HIV care services as well as other co-occurring conditions like substance abuse. We're having a lot of overlapping syndemics between substance abuse and mental health and other needs of these individuals. And then states provide a little bit less on the side of STD screening, but they also are actively involved in linking HIV-infected individuals in the field to care. So this sort of just gives you a profile of what sort of is happening at the local level, at the county jurisdiction, and then at the state level. Again, we want to highlight, we've been quantifying, what STD prevention programs are doing. Each year, we've identified that they identify about 20% of all new HIV cases in the U.S. That's 8,400 that we recently estimated. They identify about 25% of all of the syphilis cases in men and 19% in females, 20% of our gonorrhea cases in males, 9% in females, and 17% of all reported cases of chlamydia in males and 6% in females. So moving to our picture of sort of the deterioration of our public health infrastructure, which is becoming more and more of a concern, especially when we start having more need with increasing burden of infections in the United States. We recently did a study looking at the impact of state and local budget cuts to STD prevention programs, which overall 52%, and this is 2012. We had a lot of budget cuts occurring earlier to this year, but we really started tracking in 2012. 52% reported budget cuts, and these were reflected in either reduced clinic hours, reduced screening programs, reduced contact tracing for chlamydia or gonorrhea because they were so overwhelmed with just keeping up with syphilis cases, implementing more co-pays and fees for clients when they come in for clinical services, and actually 7% just in 2012 reported STD clinic closures. So we estimated about 21 local health departments actually lost their STD clinics, closed those clinics in 2012, and we're hoping that patients would be picked up by other sectors of the healthcare system, which we're not sure all of them are accessing or have the ability to access. We also looked at staffing issues. And it seemed that obviously when you've got budget reductions, you're going to have less staff. Interestingly, clinicians seem to be reduced more than our DIS, but so 65% of programs had to reduce their clinicians on staff, 48% DIS. We also recognize that our DIS stand for Disease Investigation Specialists. They're the boots on the ground that do the contact tracing, do the linkage to care, do the outreach to communities that are not accessing care. And our DIS were both at the federal level, who have DIS experience as well, at the local level, were pulled to public health emergencies in 2012, 2013, and 2014. I think most recently you've heard about the Indiana outbreak. And we had about 35 DIS that were mobilized to Indiana to support the HIV work in that area. We also had a number of our staff that were detailed to Ebola contact tracing in Sierra Leone, Guinea, and Liberia. So obviously when staff are moving to other programs to help out with the skills that they have, they're not home to be taking care of our STD efforts, and we feel like this has been having another major impact on our activities. So overall, there's been a decrease in staffing from 06 to 11, and a mean of about 3 staff. There's an interesting analysis that one of our health economists, Dr. Harold Chesson, has done. We had a syphilis elimination program. We actually thought we could eliminate syphilis in 1999. We thought we had the tools. We were at the lowest rate of syphilis ever in this country, and we even had places like Seattle that didn't even report a case of syphilis back in 1996. And we were actually able to look at, so we had dedicated funding, federal funding for our syphilis elimination efforts. And what it showed us is if you invest in syphilis elimination, which is the pointer here, the lower bar, you can see that we were able to mitigate the increasing rates of syphilis to about 0 in the programs that we were able to fund. But we didn't have enough resources to fund everyone, and so you can obviously see here on this graph that there were significant increases in rates of syphilis in those areas that did not receive syphilis elimination funding. So we know if we have the resources, we do have some tools that can mitigate these increases. We also are concerned that we know there's still some vulnerable populations with STIs that really are not being reached by the Affordable Care Act. And again, we recently did a study looking at an estimate of the number of people we think that are currently both uninsured or underinsured in need of STD services. So in 2016, we estimate there's about 4.6 million people that really are in need of insurance and in need of STD services. And we did an estimate of just chlamydia alone. We've not yet done this for gonorrhea or for syphilis. To fill this gap, we would need $150 million. And if you happen to notice my little budget that I didn't highlight, our total appropriation is about $154 million. So clearly, we recognize that we are underfunded to really meet the needs of these uninsured populations that are vulnerable and at risk, and unfortunately have not been able to take advantage of the Affordable Care Act. So this is the reason why we believe there's still going to be need for publicly funded STD services. We also want to assess why people were coming to STD clinics. We really didn't have the science. A lot of providers think, well, I can take care of those patients. Why do we need an STD clinic? So we worked with NACHO, our National Organization of County and City Health Officers, and did an assessment of over 4,000 patients seen in STD clinics. And we actually found that half the patients coming into STD clinics are uninsured, and about 1/5 were on Medicaid or Medicare. But we also found that half of them really came to the clinic for the same day kind of appointment, low-cost service, and that some of them also were being seen because they also wanted the confidential services that STD clinics provide. Interestingly, when we asked them, if you couldn't have accessed care here today, where would you have gone, or where do you get your main care? A lot of them that are seen in STD clinics report the emergency department. So they don't have a lot of primary care providers taking care of these populations. Now to transition to sort of give you the punchline to our resurgence of syphilis today. We want to share with you our concerning trends. And I also just want to remind everyone, if you don't know, I know we have a lot of awareness days and a lot of awareness months, and but April is STD Awareness Month, although we like to think every day is STD Awareness Day. So for those of you who are more techie than I am, because I still have a flip phone, we have a talk, test, and treat, and there's going to be a thunderclap tomorrow, so we really encourage those of you who like to Twitter and do other things to go onto our website and hashtag STD Month 16 and participate in the conversations that we're having about talk, test, and treat for STD prevention in the United States. But first I want to show you what I consider a sentinel concern that we have in the United States. We are now seeing increases of congenital syphilis to the point in 2014, that's the highest number of congenital syphilis cases we have seen in this country since 2006. So we're talking 20 years of congenital syphilis going down in the United States. For those of you who are not clinicians, in most people's assessment, congenital syphilis is a sentinel event. It is a failure of the healthcare system, and it's a failure of the public health system. And in a society that invests as much as we do in our healthcare and in our public health, we should not be seeing this number of congenital syphilis cases in the United States. We certainly, in our projections right now, is that we're going to have over 500 cases of congenital syphilis reported in 2015. We're still in the process of finalizing our data, and those numbers really can only go up. And what we normally see is that we monitor the rates of syphilis in women of reproductive age. And once we start seeing rates go up in women of reproductive age, then a few years later we start seeing cases of congenital syphilis. So that's usually our bellwether. But if you notice on this graph, we started to see the increasing rates among women at the same time we were seeing the cases of congenital syphilis. And what we're seeing for a number of these women, and there may be some intersection with the opioid epidemic, is these women are not accessing prenatal care. So we are identifying the syphilis in the woman at the time she delivers the baby with congenital syphilis. So it shows we're really behind in terms of our prevention efforts. As you can see, it's not just something that's happening in a few places of the country. We've got congenital syphilis occurring in many different places. It seems to be based on many different root causes, and we're currently in Fresno, California, investing a large outbreak there. So we're in the process of trying to understand the whys. We do receive some data at CDC on the cases of congenital syphilis that we can analyze. So looking at our 2014 cases of 458 cases of congenital syphilis, 21% did not receive any prenatal care. And interestingly, of those that did receive prenatal care, 29%, almost 30%, were not treated. And this was because of, people didn't follow up after they had a positive syphilis test during their pregnancy. So we're very concerned, because these are things that we should be able to if we can get people into prenatal care, we should be screening appropriately, and we should be able to get them treated before and treat the fetus before the baby is born with congenital syphilis. We also have been tracking infant death in stillbirth, so congenital syphilis is a cause of stillbirth in this country. We also have major underestimates of how much is causing congenital syphilis, because many providers do not test women who have a stillborn baby for syphilis. They don't think about it. We also have some challenges that if syphilis is identified in utero and the fetus is treated, if the fetus is born normal, our surveillance system also does not capture those cases of congenital syphilis, although that's a successful treatment, so we want to view that as a success. We also have infants that are dying after birth because of congenital syphilis, so this is a morbid and mortal complication that we have the tools to prevent in the United States. We also overall are seeing dramatic increases of our infectious cases of syphilis, and this is just sort of giving you the history of where we were when we thought we could eliminate syphilis in 1999. Right now we're up to, over 23,000 cases with significant increases among men, women, and among men who have sex with men. And again, I'm not going to go into the details of all of the data that we have at CDC, but we clearly are seeing this in sort of all regions of the country, as well in both genders, and especially among gay, bisexual, and other men who have sex with men. So this is a summary of our cases of primary and secondary syphilis with sex and sex partners in 27 states. We still are not having all of our states who've been consistently reporting gender of sex partners, so we are able to look at least a representative sample. And as you can see by the gray-black line, for men who only report only male partners, we've seen this incredible increase for a number of years. It's probably been going back to the advent of HIV treatment. A lot of people are sort of saying now it's all because of PrEP. Well, PrEP really just became available sort of in 2014, and you can see that there really is not a significant increase in syphilis at the time of the implementation of PrEP, and obviously PrEP is just being scaled up in the United States. In addition to our concerns about congenital syphilis, we are also seeing an unusual form of ocular syphilis. We do know that syphilis can get into the nervous system and can cause neurosyphilis in about 1% of individuals that have early infectious syphilis. But we've been starting to see more cases than we normally would expect, and I was in San Francisco in the STD program back in the late 80s and early 90s when we had no treatment for HIV, and we would see some decreased vision, blurring of vision, things like that, but blindness, never saw a case. And I had a lot of cases of syphilis in HIV-infected individuals in San Francisco at that time. So we're in the process of evaluating the impact of this adverse outcome or complication and site of infection of syphilis. We've been working with North Carolina on an EpiAid. These are preliminary data where they really started seeing increases and really wanted to say, is this more than what we would expect? So basically, they in just 2 years, and this is sort of a state that has about a medium amount of syphilis, they identified 63 cases. Now there were 20 cases in 14 and there were 43 cases in 15. Predominantly among men, 56% were HIV infected. But interestingly, we didn't really find a smoking gun. We found cases all over the state. We did not find partners that had a case of ocular syphilis. We're thinking maybe there's a new strain type that's circulating that's more likely to invade the nervous system or invade the eye. But we did also document that a number of them are having significant vision loss. So this is something else that we are trying to do more surveillance around the United States to understand the magnitude. But at least from this data, it looks like the increase in ocular syphilis is more than we would have expected compared to the baseline of STDs that we have. So, to summarize, we're concerned about the increases in congenital syphilis, which from 2013 to 2014 was 28%, and I can tell you from our preliminary data in 2015, we think that is going to increase again. We're concerned about our high levels of syphilis among men who have sex with men. Really, we're back to the level of disease, burden of disease in gay men that we were seeing before HIV in this country. We're concerned about the erosion of the public health infrastructure and how this is impacting our ability to respond to these epidemics and endemic problems with the reduction in boots on the ground staff and closure of STD clinics. And obviously we are excited about the Affordable Care Act and having opportunity for people to have more coverage, but we recognize there's still a lot of unmet need out there that needs public health dollars. So thank you very much.
Good morning, everybody. It's a pleasure to be here with you today. to basically discuss everything that Dr. Baldwin mentioned. That's happening here in DC, it's no surprise. And thank you, Bill, for letting me know that everyone on Capitol Hill has gonorrhea or syphilis or chlamydia.
Coming to you, Travis.
Right, we're coming up. So we're ready to take care of you. And I'm going to share with you this morning some of the features that we have in place to help take care of that if that were to potentially happen. So talk briefly about some of the surveillance updates in terms of the data for what we're experiencing and seeing here in the district. A lot of this will not be a surprise based upon the presentation that you just saw. A lot of the numbers are consistent with the district. We'll share with you some of the current features of our clinical program, as well as talk through some of the features of our larger division within the Department of Health, discuss with you some future directions and goals, and the continuing theme of the day, talk about how those challenges and obstacles that Dr. Baldwin mentioned significantly impact the work that we do at the local level. And just for financial purposes, I have no disclosures to disclose. However, I will say that, as a local public health department, we do have in DC, we do function also as the state Department of Health. And we do receive a significant amount of funding from the CDC as well as a number of other government entities to do the work that we're doing. So, you might have heard we have some issues with STDs and HIV in the district, particularly around HIV. At CROI this year, there were some statistics released that in the district, residents have a 1 in 13 risk of becoming HIV positive. For Black MSM, that lifetime risk is 1 in 2. And for Latino MSM, that lifetime risk is 1 in 4. So we take that very seriously here in the district. And so not a surprise, and I'll start with you and share with you some of the information around our HIV statistics. So this information is from our interim report from 2014. This was also the first time that the district included multiple boxes for gender identity, and so we were able to include individuals, transgender individuals, in the number. We saw 396 cases, 79% were male, 17% were female, and it's important to note that what's different in the district from a lot of other jurisdictions is we do have a significantly high number of heterosexual identified women who are HIV positive. And 4% identify as transgender. And unfortunately, I don't have the breakdown between the slide here between transgender male and transgender female, but I will say of the 24 cases that were reported, 20 were reported as transgender women. So when we look at the modes of transmission, again, as Dr. Baldwin pointed out, the majority of the cases are tied to sexual transmission. So within our schematics, 59% were direct sexual contact, and within that number, 66% were identified as MSM, men who have sex with men. 17% were male heterosexual contact, followed by 14% female heterosexual, and 3% transgender sexual contact. Now, it's interesting to see now that we have gender identity inclusion in our statistics, it will be interesting to chart how that number will likely increase, because now that we are getting that data, we're seeing that young transgender women in particular are seeing significantly high risk profiles for HIV acquisition. I can speak, as Bill mentioned, I just came from Chicago in October, so not new, completely entirely new yet. But can speak in Chicago, we were seeing for young transgender women risk profiles as high as 40 times higher than even young MSM, the same age group. So HIV doesn't happen in a vacuum. It tends to pick up some friends along the way, as we see some profiles across the district and across the country, particularly seeing HIV co-infection with hepatitis C, and HIV co-infection with our dear friend syphilis, who is a special guest today. So in looking at cases of syphilis in the district, this looks at from 2008 until 2012, we see an increase in the number of cases that mirrors what Dr. Baldwin pointed out over the last several years as the trends continue to move forward. And we see that 97% of those cases are male and 3% are female. And I can attest that we actually do have a new case, unfortunately, of congenital syphilis that presented this week. I was in clinic seeing a young man on yesterday, who came came in because his female partner delivered their kid at the hospital, and both the mother and the baby were found to be positive for syphilis. And so the hospital informed him that he should come get screened and get tested and treated. And because of the resources that we have in place in the local public health department, I was able to screen him, to start him on treatment, link him to our disease intervention specialist, which we'll talk about shortly, and has already been mentioned. And within the span of 2 hours, we were able to track down all of the contacts and be able to get the medical records of the baby's mother, the child, and ensure that the child and mother were adequately treated, and being able to task our DIS folks to be able to follow up with the male partner to make sure that he was adequately, or he will be adequately treated over the next several weeks. And unlike some of our new other STDs, we do see a little bit of an age skew towards the older population in terms of having higher cases, higher number of cases of syphilis in the district. And it's important to point out, when we did get news of the congenital syphilis outbreak across the country, myself and Dr. Lindsay, who is the Deputy Director of the Community Health Administration, a sister agency within the Department of Health, sent out a public health warning to pediatricians, family practice physicians, obstetricians and gynecologists to remind them of the outbreak, as well as remind them of when proper testing should be done in first and third trimesters, as well as reminding them and updating them on what the treatment recommendations are. So again, this is another component and feature of the local health department that goes beyond just the screening and treatment endeavors that people come into the clinic for. Okay. So syphilis has another friend in gonorrhea. All right. Gonorrhea, we've seen a rise in cases as well over the last several years. Again, our data, our surveillance data is formalized up to 2012, which is a challenge, which we'll talk about at the end of the presentation. As you notice, some of our numbers aren't quite as up to date as the CDC, and that presents one of the challenges of local public health offices being able to provide that surveillance support and epidemiological support, given the constraints we have in terms of funding and being able to hire staff. But when we look closely at gonorrhea, we do see over almost 2,600 cases. And anecdotally, I can tell you that that number is increasing. I don't have the official data to suggest it, but anecdotally that is true. We do see a higher distribution of males who are impacted, 58% males and 41% female. Can you guess what the age distribution is? Is it similar to syphilis? It's younger. There we go. So we do see a skew in the different direction. The age groups that are disproportionately impacted are 15-year-olds to 24-year-olds. See high rates of gonorrhea, and we see high rates of chlamydia as well. Chlamydia rates pretty consistent, higher numbers, but this percentages are higher in females, 64% female. But we do see a similar age distribution in comparison to gonorrhea, which again is different from syphilis. Now, I did not include any schematics that showed the geographic distribution of these cases, as well as the racial breakdown of these cases. We do see some disparities, particularly around geographic distribution here in the district. You know that we are on a ward system. There are 8 wards in the district. Wards 7 and 8 in particular have significantly high rates of chlamydia and gonorrhea, as well as our HIV numbers are pretty universal across the board, with the exception of, I think, Ward 1, with the higher numbers being in Wards 5, 7, and 8. And so you can imagine this presents some challenges when trying to reach out to different coalitions of populations to be able to provide education and outreach, as well as do disease investigation. And as Dr. Boland mentioned again, it's challenging because back in the day, when flip phones were in, and according, I have an iPod, and one of my younger staff members was like, "You have an iPod?" Yes, I do. So back when technology hadn't quite advanced to where we are today, people met the old-fashioned way. But now people meet online. There's all sorts of apps, whether electronic or based upon your phone, and people interface and exchange connections in many different ways that our surveillance system hasn't been able to get up to date to be able to track and monitor the spread of disease. So, let me tell you a little bit about our program. The core of our program is our STD clinic. HOSTA, as Bill mentioned, is HIV/AIDS, hepatitis, STDs, and tuberculosis administration, which is one of the 5 core agencies of the DC Department of Health. Within our division, we have the Care and Prevention Service, which provides and oversees our Ryan White funding, which provides a lot of support for individuals who are HIV positive, from ADAP assistance in getting drugs to housing support and things like that. We have a dedicated prevention division as well that does a lot of work with community agencies to deliver prevention methods, whether it's the standard old-fashioned safer sex condom distribution or investing into some of the more modern techniques, which we'll talk about, I'm sure, in the scope of the discussion. And we have a robust surveillance division as well that tracks not only the diseases in the STD clinic, but diseases throughout the district, as well as an epidemiology branch within that provides support in terms of being able to provide analysis in terms of outbreaks and so forth and how to target and tailor our interventions. But the division that I'm responsible for and can talk very closely about today is our clinical program. How many of you know where the Southeast STD Clinic is? Good. We'd love to have you for a tour, but I'm very happy to say that we'll be moving to a new clinical facility, hopefully by next summer. And Dr. Boland did tour that spot last week and was quite excited to see where we're moving. But the current location is on the DC General campus. Our lab services are all external. We do contract with an outside commercial laboratory to provide lab support. We do utilize disease intervention specialists to do outbreak investigations, as well as to be able to provide treatment verification for some of our reportable diseases. As I mentioned, we have a pretty robust surveillance program that provides analysis and outreach for those services. We are happy to say that we are modernizing our program. We implemented electronic medical records back in December. We're working on building a better, more efficient, and seamless system in terms of electronic lab reporting, not only for our program, but also for others throughout the district. And can you guess how much we charge for all of these services? Currently, they are all free. But we will be working on that to implement a billing model. You might have heard funding as an issue. So some of the current clinical algorithms that we have, so if you come into our clinic program, it is appointment-based to add some structure to that. We do routine testing. Our routine testing profile includes multi-site gonorrhea and chlamydia testing, including the urine NAT test. We do syphilis testing. And what's different here in the district in comparison to a lot of other places is because of the rates being so high here, we require everyone to get a syphilis screen as part of their routine testing package. We do utilize 4th generation serum-based HIV test, which represents the newest technology. And some of the other tests that are optional, depending upon your physical exam or your symptom history, include hepatitis, herpes, trichomoniasis, and bacterial vaginosis. And I'd like to say that as best as I can tell, all of our testing is up to date per CDC guidelines. And this is a challenge for a lot of local public health offices because especially if you're funding and paying for those lab services, the newer technologies aren't that cheap in some cases and do represent a challenge when you're trying to meet budget constraints and so forth. We are fortunate to be able to offer those in addition to implementing a new program, which will be starting within a matter of several weeks. We will be running a PrEP and NPEP program. PrEP is for pre-exposure prophylaxis, and PEP is post-exposure prophylaxis. We will be implementing that program out of the STD clinic, which would involve having folks come in, helping them get an initial prescription for PrEP services, as well as work to link them to financial resources to help them pay for it, as well as being able to complete their maintenance labs every 3 months, including metabolic profile, and you guessed it, we do routine STI screening as a part of those visits. Notice a theme here, HIV and STIs connected at the hip, and we test frequently for those services. So in addition to our clinical programs, we do some other type of stuff out in the community that helps bolster our clinical work. We do a fair amount of youth-focused programming, and I confess this was in the works before I got here, but you can imagine as an adolescent medicine person, I'm quite excited to see this, and we'll continue to move this forward. Two of our programs that I'm very happy to highlight are the YSSP program, the Youth STI Screening Program, and our school-based screening program that we partner with the DC Public Schools and the Office of the State Superintendent to perform. Both of these offer particularly urine-based gonorrhea and chlamydia screening access to young folks and linkage to care and treatment services for those who test positive. Unfortunately, we're seeing as high as a 30% reinfection rate among these young folk. And even though we're not seeing high rates of HIV, in fact, several years ago, they included HIV testing as a part of it and didn't find any cases, we know that STIs are the gateway to future HIV infections. And so we continue to do these programs and increase our partnerships with other agencies, such as the Division of Youth Rehabilitation Services, as a part of our YSSP package, as well as continue to work with the DC Public Schools. Currently, we're only doing the screenings in public schools, but hopefully we'll be able to increase the partnership to make sure that we're expanding beyond just the high morbidity schools that we see in the district. So in terms of volume, we see roughly 10,000 clinic visits a year in our current space. We're hopefully that the new space will be a little bit more attractive and easily accessible to folks in the community to see that number go up. We see roughly 3,000 students as a part of our school-based program and screen approximately 2,000 young persons as a part of the YSSP program. We do also provider education. We try to do targeted training. For example, these are some of the key activities we're doing. Targeted training for high chlamydia morbidity providers to routinize screening and try to figure out what are the best practices being done in the community, take those best practices, share with other providers, and be able to serve as a resource for training for those who say, I'd like to do it, I don't have the infrastructure to do it, I'd like to do it, I don't know how to do it, or I have no idea what you're talking about, can you tell me what I need to know so that I can implement it into my program? Some of the other features that we're pushing forward are expedited partner therapy, which is in particular very significant for young people with gonorrhea and chlamydia, being able to provide them with the resources for their partners to get tested or to get treated to cut down on those rates of reinfection. And globally, the big issue of routinizing STI testing and making it a normalized part of clinic visits, because as when Dr. Bolin asked how many of you get asked, who your sexual partners are, all those kinds of things. We're seeing that not everybody's getting screened for these STDs, and I would imagine that has to do with some of the discrepancies in the percentages of males getting tested for one thing and females getting tested for others. One of the last components I want to highlight is we recognize that we can't operate in a vacuum. We have to provide solid clinical care. We have to provide solid educational and training resources to folks. But we also have a responsibility to do some research and find out what not only the best clinical practices are, but be able to tie folks in the communities that are traditionally and disproportionately left out of a lot of other conversations, to cutting-edge screening methods, to cutting-edge treatment methods, and to cutting-edge research trials that may significantly impact their health outcomes. So we are one of these are recent changes. We are one of the new research sites for the DC Center for AIDS Research, the DCCFAR. We have a formalized academic partnership with George Washington University School of Public Health. This is something that has predated me and we continue to bolster. They provide us with a lot of support around our epidemiology branch. As Dr. Bolin mentioned, CDC does embed different staff members in other areas. We have a CDC embedded medical epidemiologist, as well as several staff members who are CDC employees who provide us support and surveillance. And one of the new things I'm happy to say is we don't have an exact name for it, so don't quote this in the papers, but we're building a Center for Clinical Research and Population-Based Studies to be able to take what we're doing, get it out there into the community, and help partner with other public health offices to try to figure out how to answer some of these questions. So for example, one example is in February, we're interested in potentially being able to offer hepatitis C treatment out of the public health department. We don't know how to do that because we don't really have a sense of what hepatitis C looks like in the district. So we tested everyone as a part of the routine screen back in February. We didn't actually find anything super significant in terms of any particular demographic group being disproportionately impacted outside of the CDC recommendations. But it does give us an opportunity to reach out to providers, to extend that conversation, to be able to help think through how do we change and update those clinical algorithms to make sure that we're meeting the needs of the communities. And for example, we're partnering with a group from the University of Maryland and the National Institutes of Health that is doing a research study basically to address that, to try to figure out what the point prevalence of hepatitis C is throughout the region and try to do targeted preventative work in those areas. So some of the future directions, in spite of these challenges, we will continue to push forward and do these things, hopefully with good, robust funding across the board from CDC and local dollars. As Dr. Bowman mentioned again, expedited screening and treatment. Without internal lab capacity, you come to the clinic, I can do your swabs, get your blood. It's still going to take a week turnaround for you to get your results back. And unless there's a clear slam dunk history or symptoms presented in terms of treatment, you can imagine what can happen within 7 days. We're seeing 30 to 40% of people potentially lost to follow-up who may have positive results and aren't getting treated. And so the idea is to try to build a clinical model that will allow us to do that. You can come in, you can get screened, you can get treated, all within a 1 to 2 hour period. Imagine how beneficial that would be to disease intervention and disease prevention. So one of the things we're trying to do is to figure out how to build internal lab capacity, figure out how to utilize technology to enhance adherence, whether that is coming to the doctor, reminding you of your lab results, or if you are started on a medication, for example, anyone who might be Hep C positive or HIV positive, utilizing and thinking through how to use technology to improve that, because we know that, especially with HIV, treatment as prevention is emerging as probably one of the biggest strategies in terms of cutting down on the number of new cases. Continuing to support and enhance surveillance and epidemiologic capabilities. I intentionally did this. Well, one, I didn't have 2014 data to show you, but it is a challenge. We're strapped. We're dealing with a lot of cases to have to go out and verify treatment and collect that data in a cohesive manner to be able to roll that out to you. So when you get these reports that are released and you say, well, it's 2016, why are they just telling me about 2013 and 2014? That's a byproduct of the limits of the system. And one of the things that we underscore in terms of continuing to have that support to provide up-to-date information so that we can chart and monitor and provide effective targeted interventions to address disease. And lastly, looking to create some new clinical offerings. For example, we are looking to potentially add hepatitis C to our treatment profile, as well as improve our ability to treat those who are HIV positive. So currently, if an individual tests positive in our program, we have a red carpet entry system that guarantees them a visit to a primary provider within 72 hours. We are seeing, fortunately, with that system, approximately 80% of folks are linked to that initial appointment and actually go. But we have to do more in terms of addressing not only that initial visit, but all of the other factors that might arise that influence and can impact their adherence. So that concludes a vision of DC. I'm sure we'll answer some more questions, but again, come by and visit us sometime.
So really quickly before we move to Q&A, so thanks both to Dr. Gales and to Dr. Bolin for two really great presentations. And I hope what comes across is that the challenges are enormous, and yet the innovative thinking that's going on, I think, is really the type of future that we need to head into, particularly the things that Dr. Gales was presenting. So there's a reason we're up on the Hill. Which is, yes, we want to raise awareness around what is going on across the country with these diseases. But obviously, we want to talk a little bit about money, because the money is pretty thin. So when I first came to NCSD 6 years ago, when I heard we had about $150 million in federal investment going into our nation's STD prevention, I was shocked. because in the broad scope of things, that's not an enormous amount of money. And as Dr. Boland underscored during her presentation, the STD prevention work across the country in state and local health departments and territorial health departments has always been a collaboration between state and local dollars as well as the federal government. But we have seen significantly diminished contributions from state and local resources. In fact, there are a number of states right now across the country where there isn't a single dollar other than a federal dollar that supports their STD program. We're trying to fix that because we think that payer mix for a program isn't quite right. This is a state responsibility. But the reality is that if we look across the country right now, I'll give you Kansas. If you look at Kansas, there isn't a single state dollar going into STD prevention in Kansas. It is all federal dollars. This graph represents, the blue line represents actual federal dollars for STD prevention that go to the Centers for Disease Control and Prevention. And if you look, it's essentially flat. And in fact, it's a little bit of a decrease in terms of real dollars due to rescissions and sequestration and some other things. However, the yellow line, if we adjust for 2003 dollars for inflation, we have actually lost almost 40% of our buying power because of the flat funding since 2003. And this is set against, I'm not sure Dr. Boland mentioned it, but this is set against the recent STD surveillance data from 2014 showing us that for the first time since 2006, chlamydia, gonorrhea, and syphilis are all on the increase at the same time together. What does that mean? That means we're seeing more and more disease, and we're seeing less dollars in order to deal with it. And we used to have a mantra that said, we're trying to do more with less. And let me just tell you, we're not doing more with less anymore. We're doing less with less. So when Dr. Gales was talking, for example, about contact tracing and the important work that staff and local health departments do to find contacts of a positive patient, it is quite frequent now that in jurisdictions with lots of syphilis, for example, that there's no contact tracing going on for gonorrhea. This is not a good dynamic because that's the type of thing that leads to disease spread. In fact, I will say I am hard-pressed to think of a single jurisdiction right now that does chlamydia contact tracing because there's so much chlamydia. So we need additional resources in order to deal with this. I also just wanted to point out and underscore that while there are different dynamics going on in terms of populations impacted, the trend is across the country. There isn't a single region that is experiencing any type of decrease whatsoever in terms of primary and secondary syphilis rates. In fact, if we put some numbers to this graph, you'll see that over the last 10 years or so, there's been almost a doubling of primary and secondary syphilis cases in every region of the country. So it's not the West, it's not the big cities, it is local towns across the country that are seeing these increases. And also just to underscore, there wasn't a single demographic in the 2014 STD surveillance data that escaped an increase in primary and secondary syphilis. So that includes heterosexual women, it includes heterosexual men, and everything in between. So we are up here with what we think this year is a relatively modest request of $8.1 additional dollars going to the Division of STD Prevention for FY 2017. We recognize, as Dr. Boland mentioned, that we're taking advantage of every opportunity of the evolving healthcare delivery system, including the Affordable Care Act. Dr. Gales has mentioned some really revolutionary thinking that's happening in a number of health departments across the country to think about what taking advantage of billing and reimbursement systems and better service delivery looks like, but we still have nearly 5 million people, I think through 2023 is the date, who will need safety net services in STD programs, and we simply cannot continue to do it without additional resources. So we are asking for 8.1 million, but also with some very specific priorities. So we've talked a lot here about the dwindling workforce. We're asking for 5.1 million of that 8.1 million to go towards state, territorial, and local health departments to hire those boots on the ground that are doing contact tracing, that are looking at data and surveillance data and epidemiological data that can inform programs so that we can do a better job of dealing with syphilis and of the other epidemics that we have. But the workforce, as vital as it is dwindling. And yet it is so vital that every time there is a case of Zika, STD is Zika, sexually transmission of Zika. We can't get out of here today without talking about Zika, right? With sexually transmission of Zika, it is the STD staff who are called in to help figure out where those contacts happened. They're called from CDC, they're called from state and local health departments. If they're called off of doing their regular work to deal with Ebola or to deal with Zika, they're not doing the work in the STD program. We need more money to hire more bodies. And our NATO study has also underscored that we've seen cuts in the workforce as well. And finally, Dr. Gales, I think, underscored for us that we are, at the same time that we're dealing with all of these dynamics of decreased resources, decreasing staff, increasing diseases, we need to innovate. And we need to think about how to take advantage of the evolving healthcare delivery system, how new technologies that enable us to empower patients with their data and empower health departments to act on that data creates more seamless disease intervention and time to treatment. So we need to think about what those types of innovations look like. There's also all types of, Dr. Bolin underscored that we are having some surveillance challenges. So there is no national system for STD surveillance on the ground. The states have different types of systems, and they all are in the process of being updated or need to be updated. Those things cost money, so we need some additional work to focus on that. But the bottom line is we really have to invest in innovation and developing the research base so that we know how to spend our dollars wisely. So this $3 million that we're asking for out of the $8.1 million would really go toward those types of interventions on the ground to help us understand what really needs to be done to expand the research base. So with that, let me just thank our honorary co-sponsors and our organizational supporters for today. And now we've got some time for any questions that folks could have for any of the speakers. Okay?
Hi, I'm Penny Starr with CNS News. I want to just make sure I understood what you said, just clarify. You said that 40%, that transgender women that you've surveyed are 40% at risk, higher risk for HIV transmission. Was that the statistic you gave?
No, so I was using an anecdote from Chicago. So research data has suggested that in some places, young transgender women have HIV infection risk factors at 40 times the rate of other groups, including MSM. So there's a number of different studies out there that suggest that. In DC, we don't know because we just started asking. So it'll be interesting to see as that data comes in to see if that holds true for the population.
Dr. Bolin, I wanted to ask you about, you said that the greatest increase in syphilis was among men having sex with men, but you didn't give a number on that or a percentage or anything. And I just also wanted to clarify that you said the highest rates of syphilis are now in effect since before the HIV epidemic. That latter part is correct?
Yes, so we're starting to see rates of syphilis that we saw in this country before HIV.
Right.
On average, we've been seeing about a 10-ish% increase over the years, but I can say in our 2014 surveillance report, which is the last surveillance report we have published, we're certainly working to get our 15 surveillance data together. There was a 15% increase of syphilis among men.
And how does that compare to the last report?
It was a few percentage points higher. I mean, we're concerned that's a pretty significant increase to be seeing on an annual basis.
So it's been steadily increasing?
Yes.
Penny, I would just say that there's a great slide set on the CDC website with the 2014 surveillance data.
Okay.
That would be helpful for you.
That one would be helpful. Thanks.
Other questions? Great. Well, let me, I think out on the front table, we do have a write-up of our support request for FY17. For those of you from congressional offices, please reach out to us. We want to be your resource on this. But please help us during the appropriations process this year with what we think is a really relatively modest request with some really targeted investments. And my colleague Stephanie Arnold-Pang would be more than happy to chat with you, although you probably already chatted with her already, but she's here as your resource. So thank you all for coming, and please take some of the Danishes back to your office.